finish that preview.
Welcome back. Sorry, I'm just trying to get my pronunciation correct. So Stephanie, do you want to come up and join us? I would love to. We're going to start with you and then we'll pivot to Dr. Friedman. Can you give your testimony?
If it's easier, I'm referred to in my practice by my colleagues as Dr. Lisa.
Thank you.
I can do that.
Okay, good morning.
Refer to everybody by their first name.
I'm Stephanie. Good morning. Thank you for having me. Stephanie Winters. I am the Deputy Director of the Vermont Medical Society. And in that role, I also provide Executive Director leadership to the Vermont Psychiatric Association and the Vermont Academy of Family Physicians, who I'm going to be speaking on behalf of today. That represents over 3,000 physicians from across specialties across the state. So thank you for allowing me to testify today. Before I begin, I do want to thank the committee for your continued support and prioritization of primary care through legislation to remove administrative burden hoopla from last year, and also the budgetary prioritization for primary care support. So really appreciate that, and I don't want that to go unacknowledged. Back to the topic of H237. We've been involved in discussions on this for a number of years. We participated in the Office of Professional Regulation public hearings, the Sunrise reports. We submitted written comments, which I sent to Kristen, and you can see those are from 2021. So just, they are not updated to this current legislation, but they have a lot of the same information that we're looking at. And we, as some of you know, I also work with pediatricians. So they always say, talk in strengths-based language. So I'm going to do a strengths-based sandwich. I'm going to start with positive, talk about some concerns, and then end in a positive note, hopefully. So we're happy to see some of the recognition of the complexity of prescribing psychotropic medications in this bill, with the exclusion of youth, those over 80, pregnant people, and a requirement for collaborative practice. However, we're still concerned that this bill needs more discussion, review, and as currently drafted, continue to have concern with expanding the scope of psychologists to include prescriptive authority. I would recommend that you hear from hopefully the Board of Medical Practice, who has weighed in on this before, and also the National Alliance on Mental Illness, who does not endorse this legislation as well. While psychologists are experts and important behavioral interventionists and highly valued members of the healthcare community, the proposal before you would not provide adequate clinical training to expand their scope to include prescriptive authority while adequately protecting the public. And I think proactively, I will answer your question about OPR at the end. Yep. I think you're going to ask me about that. I think one of the things I wanted to highlight, and it goes with some of your questions about workforce, is that we have not seen evidence that authorizing psychologists to prescribe will increase access to needed mental health services in Vermont. In other states where this has been done, and I think we're approaching 2 decades in some of the states, the numbers are still extremely low. So nationally, there's 215 psychologists that are licensed to prescribe across 6 states. There is a 7th state that just passed, and so there's not numbers from that yet. But in my testimony, it outlines how many in each state. I think Louisiana, I believe, is the longest. So they do have a larger number. They are also a much larger state than we are and have a bigger populace. But they are by far the largest. So Louisiana is 118, New Mexico is 63, and then you go way down from there, 15, 12, 4, and 8. So it is not a huge access gain. And with risk, we just are trying to weigh the benefit to the risk. Also, states that have granted prescribing authority have not experienced significant migrations of psychologists into underserved areas, which is what we want to see. They tend to be in some of the same places that psychiatrists are in the metropolitan, if you can call anything in Vermont metropolitan, but the more populated areas of states. I think I will leave a lot of the talk about the dangers and complexities of medications to Dr. Katapano-Friedman. She's a psychiatrist and she is clinical. I am not, but just to say that I liked the comment about mental health medications. They're not simple and they're not easy and they shouldn't be taken lightly. It's very akin to another scope of practice issue that we're talking about, surgery, right? Would you, it is not a second class form of treatment, and we should treat it as important as it is. Psychology programs are highly variable, so they don't have the same amount of regulation, accreditation, and standardization as medical training programs do, APRN, PA, and MDDO training. So that is a concern that we have, that you could come from one school and have completely different training from another. And the training overall seems to lack the preparation in basic sciences, the whole biomedical. I think Lauren Hibbert was struggling with mental health and physical health, but I think we can term it like the biomedical training, the whole body. And in fact, we agree with the Office of Professional Regulation when it stated, we cannot recommend scope expansion in precisely the form sought. The clinical medical component of the training proposed does not compare favorably to that required of other master's level behavioral health prescribers, which stands as the consensus baseline for assurance of clinical competence to prescribe psychotropics. So now,
Can
yes.
I interject and ask, would you support the change of language that the Office of Professional Regulation regarding clinical rotations through 9 specialty, 8, 7,
9.
9?
Yeah.
Okay.
So I will say that we don't currently have a specific position on the additional training, but this would standardize training and add important experience. And we agree with OPR that what is in the bill currently is inadequate. So now, as promised, I will end on a positive note and acknowledge that access to mental health and psychiatric services is a legitimate concern in Vermont and nationwide. The good news is that there are evidence-based answers that address access to care while maintaining quality prescribing. Many of those efforts are already happening in Vermont, and in a limited way, and expanding them would be of significant benefit to the health of Vermonters. So first, thank you for prioritizing the continuation for the Blueprint for Health and Dulce expansion pilots to assist practices to address mental health and substance use disorder and social determinant of health needs. That is a huge help and a huge support to primary care, who is a large pool of prescribers for mental health. Increase retention and recruitment of psychiatrists in Vermont. There are a number of ways to do that: enhancing loan repayment, improving the ability for psychiatrists from outside the state to practice in Vermont, and improving reimbursement for psychiatry, especially in Medicaid. Reimbursing psychiatrists and primary care practitioners for consulting with each other. And then increasing access for primary care practices to the collaborative care model. And one of the specific programs that I want to highlight that we're already doing. And Representative Burbecko and I met with Dr. Greta Spotswood about the Consultation in Psychiatry Access Program, Vermont CPAP. That is specifically for youth and perinatal people, pregnant people, but that would allow patients to receive care in their primary care offices, or it does, but they're currently grant funded, federally grant funded. So they will be looking for funding in the next fiscal year.
So I'm sorry, are you saying federally funded is going to be lost? I mean, we don't know.
Well, it will. The grant ends next.
So there's a grant, so that's a definite.
Yes. Yeah.
Robert, did you have a question?
Yes.
Yes.
The testimony that you're giving now,
Yes.
could you tell the committee how that relates to the bill that we're working on?
It relates because it is alternatives. It is ways that we can bolster our mental health system potentially without
Okay.
passing the bill without doing that. So they are mental health supports for our entire system that would provide much needed care for Vermonters.
If we're talking about having psychologists be able to prescribe medication.
And you want to do that to provide more access to care for
Right.
Vermonters, which I'm saying there are other ways. I'm adding the positivity.
A piece of bread on the sandwich.
That's right. That's right. So I will actually end. You have my full testimony. There's more in there. But I'm happy to answer other questions. But as I said, Dr. Catapano-Friedman Dr. Lisa is the clinical expert, and she will give you more detailed testimony.
Leslie, I just went through your testimony and the last bullet, of course, caught my eye as an APRN. What does that look like?
Well, so currently UVM, so the bullet is support funding for the Psychiatry Advanced Practice Registered Nurse APRN program at UVM. They currently have an APRN program that I think they just brought back, if I'm correct. But they were talking about having an actual pathway for psychiatry advanced practice registered nurse. And so it would be supporting the College of Medicine, the Department of Nursing to do that.
To bring back that path or to,
Yeah. Yep.
but we haven't heard from them. I don't think.
No.
Okay.
Do you happen to know, because I have a question regarding this and then something else, and if you're not able to ask this, maybe Dr. Hughes or Dr. Lisa might know, but for advanced APRNs to become a psychiatric APRN, do you know what the additional training is on that? How many years?
I don't.
Or
I don't. I could assume, but I'm not going to do that. I can do some research on that.
I'm not sure if Dr. Lisa wants to weigh in because I see she just went off of mute.
I could weigh in a little.
A little bit.
Yeah. I can tell you just some of my experience I have a nurse practitioner in my practice, and in a bit, I will get into what my practice actually is. And she has been practicing for years. She's superb. She's been practicing for years in largely in the field of neurology. And she would like to become certified, basically, in psychiatry. So what she is doing, apart from the work that she actually does for us in our practice in other ways, what she is doing is sort of an externship with me right now, where I see every patient she sees. She sees every patient I see. She's here 2 days a week to do that. And that's gone on for almost a year. And then she is going to apply for the courses that she needs to take, which I believe she's planning to do at Sage in New York. And I don't know, obviously it's going to involve all sorts of diagnostic and psychopharmacological courses. And I believe It's basically like a 2 years master's program, but what exactly the courses are and exactly they cover at this point, I do not know.
My other
But-
question
Yeah, sorry.
was you were talking about like the limited number of prescribing doctoral level psychologists currently in the United States, in 8 states. And I'm wondering, and if you don't know this, maybe Dr. Hughes could weigh in on this. How many postdoctoral training programs in psychopharmacology that are accredited by the American Psychological Association? How many of those programs actually even exist in the US? Are there many and just people aren't going to them? Or is it that there's a limited number of places where you can even do this?
I think, yeah, someone else could answer that. Yeah.
Dr. Hughes, do you know that? And
There's a limited number of them. There's, if I remember correctly, it's 6. I think there's a 7th in the works. And to my understanding, they have wait lists.
okay,
They are chronically full.
okay. Thank you. Thank you. Dr. Lisa, welcome.
Thank you. Would you like me to?
Yep,
start?
yep, you can go ahead and start.
Okay, I'm just gonna start by telling you a little bit of who I am, what I do, what my experience is. As you know, I'm a psychiatrist. I'm the president of the Vermont Psychiatric Association. I'm the medical director of the Memory Clinic in Bennington, which is why I'm not up there with you, which basically specializes in dementias and also in quite a bit of clinical research. I'm also the psychiatrist for Vermont School for Girls, which you may know is a residential school in Bennington for extremely traumatized girls. And I have a private practice, a regular, what you might call a regular psychiatric private practice, which I have had for now 43 years. So I would say I treat everything from adolescence to very old age and have for a long time. The training that I have as a physician in order to do that is, as you know, first of all, in college, I majored in biology and had a lot of science courses, which basically, amongst other things, taught me how to evaluate the validity of published papers. And then medical school is 2 years of didactic, 2 years of clinical in every field, followed by a general medical and surgical internship, at which point I have my MD, which included pretty much every medical specialty I could get, plus emergency room, plus surgery. And then 3 years of pure psychiatry, followed by a consultation liaison fellowship, which means you're in a hospital working with medically ill patients and the psychiatric ramifications of those medical illnesses. So I've been doing all of that starting back almost 50 years. And in the course of that, what becomes quite clear to me is that, as comments you've seen say, this is not trivial. Prescribing is not simple. Prescribing is not just, oh, this is a psychiatric illness, here's a psychiatric medication, check the box. It's complicated. It's complicated to the point where there's actually been consideration of making psychiatry a primary care practice, actually, under the rubric of a primary care practice, because you have to know so much medicine in order, pardon the expression, in order not to screw up badly. Yes, sometimes you will get, a perfectly simple patient A young, healthy person who comes in and they've been battling depression for a while and they've never been on an antidepressant, and you give them an antidepressant and you get it to therapeutic dose and they feel better, and that's great. That's rare. And patients don't know that they are that. So it's not that they can simply refer themselves to somebody who can do the simple, can do the basic. They don't know what they are really, and they don't know what they're going to become. And I can give you, even in just the past couple of years, the numbers of examples of patients who thought they were, in a sense, ordinary patients, who you had to know multiple physiologic systems. You had to know general medications, not just the typical, the usual. I had, and I said, I'll give you some examples. I had a woman come in her early 60s, generally healthy, who had been treated for several years now for depression. She felt miserable. She had no energy. She didn't want to do anything. She was apathetic. And she'd been on several antidepressants, finally landed with a nurse practitioner who did genetic testing, which, by the way, is not validated. And the genetic testing, according to her, told her that only one antidepressant would work for her. So that's what she put her on, would not change it. And so it wasn't working. And so she came to see me. I don't even remember how she found me, but she came to see me. And got a whole lot of history, other medications. There wasn't anything confounding in her other medications. There wasn't anything in her history other than possibly some obstructive sleep apnea, which had not been worked up, but just from how she described her sleep. So I tried her on a different antidepressant, and it didn't do anything. So about 4 months had gone by, and she came to the next appointment. And as she came into the room, she bent down to put her pocketbook down and nearly lost her balance, nearly fell over. And I was startled. And I said, "Are you okay?" And she said, "Yeah, but my balance has been off lately." She said, "I actually fell last month and hit my head and went to the emergency room. And, they did a CAT scan of my brain and they did a workup and they didn't find anything. They told me I was fine." I got a copy of the CAT scan and I looked at it, and granted, I have the expertise to read it. And I said, "You're not fine. You have normal pressure hydrocephalus." And she did. And she was sent to Dartmouth neurosurgery and she got a shunt. And lo and behold, her apathy went away, her energy improved. She felt so much better. This was somebody who presented as ordinary, pretty ordinary garden variety, depressed, but gee, her antidepressant didn't work. I've had things much more complicated than that. I've had people come in on medications that nobody, not their primary care, not their previous prescriber, whomever that was, thought about as combinations. And they were having mild physical symptoms of other things that were being worked up. And when you're taught psychopharmacology, of course, one of the things that you're taught about are some of the horrible things that can happen, like serotonin syndrome. It's usually taught in the fashion that, oh my God, you get serotonin syndrome, you get all these symptoms, you're going to end up in the emergency room because you could die. True. What you're not taught is there's such a thing as a mild serotonin syndrome, what it looks like. You find that out generally through practice. And this is somebody who was on ordinary medications that probably some of you are taking, probably in combination, who had some very mild problems with muscle spasms and tremors, and headaches that weren't getting better as a person who had a history of migraine headaches. Turned out they had mild serotonin syndrome because of the combination of medications, non-psychiatric medications. But you had to know that. There's an awful lot that you have to know about physical symptoms. In my practice in memory clinic, I work with 3 neuropsychologists, and we've been discussing this. Each one of them said, why on earth would psychologists want to do this? Yeah, it's a noble idea to get more prescribers into rural areas, but it isn't happening when people do become prescribers. They largely still stay in metropolitan areas near major medical centers. There are so many things that psychologists do that we need that psychiatrists do not do. And it contributes to decreasing the amount of medication prescribed. Most psychiatrists are not, for example, taught to do CBT or CBTI or EMDR or other trauma-related treatments. And over the years, those have been treated with mega medications that when you know how to do these practices, these procedures, you don't need medication. They work better. They're demonstrated to work better. The psychologists I work with, they're busy. I mean, these are not turf issues. Everybody is very busy. Nobody really needs more patients. They can't understand why. First of all, why would you want to, on what's really minimal medical training, minimal psychopharm training, and quite honestly, minimal supervision after one has finished this training, why would you want to risk this? Why would you want to give up what the things you do that you do so well, that we all need? Why would you want to risk this, have your malpractice insurance go up at least by a factor of 10, by the way, and that's assuming you never have been sued. Gets higher if you have been. And I think, as it sounds like has been discussed, if you look at this bill, it's extraordinarily vague. So just to look at some of the points in it. The collaborative practitioner, which is on page 2, and the definition of the collaborative practitioner is somebody licensed to practice medicine or other prescribing provider, which I assume means potentially an NP or a PA, who generally prescribes prescription drugs for the treatment of a mental health condition to their patients. So that's not necessarily a psychiatrist, because pretty much everybody at some point who prescribes psychiatric drugs for one reason or another. That's a little unnerving that it's not a psychiatrist, because that's very variable experience, understanding, training, education for a PCP or an NP or a PA. And then when on page 4, and it says regulate collaborative practice agreements, including collaborating practitioner qualifications. Yes, well, what are they? And annual competency evaluations. Who's being evaluated and for what and by whom? And then you go into the following minimal educational and training requirements on the same page. And as I said, I discussed this with the psychologists I work with, and they looked at that and they went, what? They had a postdoctoral training program in psychopharmacology, which is designed by the American Psychological Association. And they couldn't imagine how this would be feasible, how it would be complete enough, how it would in any way get close to the pharmacological training. And it can't just be psychopharm to be able to safely treat patients. It's complex. It has to be general pharmacology. How are they going to do that? And then it gets into the supervised practice, 2 years for not less than 20 hours a week in the clinical setting. What does that mean? As I said, when I teach, I also teach PA students. I'm a clinical professor of psychiatry at the Massachusetts College of Pharmacy and Health Sciences University. And they are with me with every patient through all of their 5-week rotation. What does that supervision mean? So if somebody's seeing 20 hours a week of patients in somebody else's practice, are they seeing every patient with that collaborating provider? Odds are nobody has the time to do that. Are they talking to them an hour a week about 20 patients? That's not going to amount to very much. And that turns out, assuming that people might take 2 weeks of vacation a year, that turns out to be actually fewer hours required than for a nurse practitioner to be able to practice and prescribe independently. And then it goes on to talk about completing a national certifying exam. Well, the American Psychological Association does have one. It's abbreviated PEP, P-E-P. And if you look at what the exam covers, it says 10% of it covers differential diagnosis. Well, differential diagnosis on that exam is, by and large, differential diagnosis of psychiatric entities, not differential diagnosis of this apparent psychiatric entity that turns out to actually be due to or complicated by a physical illness. And then we go on, okay, to the exclusions. Okay. Patients who are less than 18 or more than 80. And again, the comments I got from other people are, including the psychologists, are this is really odd for several reasons. Suppose you take on a patient with depression when they're 75. And they turn 80. What do you do with them? Bye? Why 80 anyway? I know plenty of 60-year-olds who are much more complex medically than 80-year-olds. Patients during pregnancy. What do you do when you've got a young woman, bipolar disorder, okay, doing well, and she gets pregnant? Can't treat her anymore? What do you do with her? Let me tell you, OBGYNs do not want to get into the psychiatric treatment of their pregnant patients for a whole lot of reasons. It's very complex, and they know they don't know. I mean, so much of this is just not fleshed out or says things that don't in all reality make sense. How can you do this? How can you do this? How are you going to determine if you're going to take on a patient who's a young woman, they'll never get pregnant? How are you going to decide, okay, I'm taking on a 75-year-old patient. I'm not going to treat them for more than 5 years. How do you know that? It just doesn't make sense. This is not real life. But the most, I mean, that's a really big problem for where I sit. But the biggest problem is that there's no way, short of getting really a pretty intensive medical education, to be able to do this comprehensively and safely. And this bill doesn't spell out in any way. This requires so much more thought. You know, one of the things that Stephanie mentioned, and I think is fabulous and is a growing entity, is collaborative care. We're already doing it informally. There's actually, and I can go into this at some other time if people are interested, there's actually a volunteer consultation program nationwide in many specialties, not just psychiatry, for primary care, particularly federally funded primary care, to get consultations that are done by volunteers in their specialties. The collaborative care practices are being created increasingly, and that's a great way to practice. That is essentially what my practice at the memory clinic is a collaborative care practice. It covers several, basically several medical specialties. Could we possibly make more psychiatrists? Unfortunately, Vermont is becoming a territory which is less welcoming to psychiatrists now that we've closed another psych unit at Central Vermont. It gets much, much harder to train psychiatrists. We've got fewer places to train them. But, you know, this needs to be thought about. How do we make it more appealing for people not just to go to medical school here, but to stay and to go into psychiatry? There are a lot of other ways to get at this, some of them quicker than others, which are safer, which create a better way to practice medicine. I mean, collaborative care, I think, is a much better way to practice medicine, because otherwise you have a lot of people, and historically this is what it's been. Psychiatrists, psychologists out there in private practice, maybe they talk to their psychiatric or psychology colleagues, but they're not talking to the primary care. They're not talking to the other specialists. And that's a big problem. But you need to know how to talk to them. You need to know what those other specialists are talking about. You need to know what the primary care docs are talking about. You need not much more than just a course in psychopharmacology. I could go on and on. I have so many other examples of patients who presented as seemingly ordinary psychiatric patients who turned out not to be. And you had to know more than psychopharmacology.
I think we have a couple questions.
Thanks for your comments. They're very helpful in the process of making the bill. Have you sat in on our committee before?
I don't think so.
I just want to make sure that it's clear that in the process of working on a bill, we invite experts such as yourself to help us write the bill. So what you're reading isn't going to be what the bill looks like if it leaves this room. So sure, it may not look like reality, some of the suggestions that were initially introduced, and that's why you're here. You're helping inform us because we don't have your expertise. So, I sense some frustration in your voice on behalf of those you represent, but please understand that's why you're invited here. We honor your expertise and hope that you can respectfully inform us and we can take that expertise into consideration as we shape the bill.
I thank you for inviting me.
Any other questions? I have a few. And you had spoken about the collaborative provider. And I take your point, sort of to Daisy's point is thank you for informing us because the collaborative provider should probably be a psychiatrist, not just any licensed provider. But I'm sort of, I think I'm sort of confused. You cite your examples and I personally worked in primary care for 25 years. And prescriptive authority is physician assistants have prescriptive authority. They can prescribe any class or schedule 2 through 5. I think they receive 3 years of, I think the average PA school is 3 years, and then they do sort of clinical afterwards. An advanced practice nurse practitioner, APRN. You said you work collaboratively with an APRN. Their training is, on par with a doctoral level psychologist who would then be going and getting a further master's degree, not just taking a course, but having a master's degree in pharmacology. Would you would you enter into a collaboration? I think you mentioned yourself that you work with 3 neurological psychologists who said that they don't want to prescribe and couldn't understand why anyone would. But would you enter into a collaborative agreement with, if we moved something like this forward, would you consider being a collaborative psychiatrist in order for this doctoral level psychologist to do training with, to learn from your expertise?
It's not clear to me what, other than psychopharmacology, is being proposed for a prescribing psychologist to learn. I teach PA students. To get a PA is a 2-year master's level program, basically. The first year is completely didactic in all aspects of anatomy, physiology, in all specialties you can come up with, pharmacology. It's pretty intense. Their second year is entirely clinical rotations, where they are on site, whether it's in hospitals or people's practices or whatever, for 5 weeks at a time, each rotation. They have, after that first year, they have the essential understanding that nothing exists in a vacuum, that you cannot treat one aspect of a person's body, basically, without considering all the others, that you cannot prescribe a drug without considering all the other possibilities of the person's body. Their actual fund of information is still pretty low. PAs cannot practice independently in Vermont. They have to remain supervised through their entire career. They have to have, or they do have, by the time that they go into practice, essentially 5,000 supervised hours. Okay. A nurse practitioner actually only has, in Vermont, has to have, I think, 2,400 supervised hours in order to practice independently, which I find a whole other interesting thing. I don't see what's being proposed for the curriculum for a prescribing psychologist to be sufficient to have even the understanding that a PA, that a rising PA has. I would have to have a much clearer idea of what the curriculum actually would be and by whom it was being taught before I would say that I would be willing to be a collaborating physician. And quite honestly, as a supervising or collaborating physician, I'm fairly intense. Nobody says what that collaborating physician really has to be doing. That's why I said I wondered about the supervised practice for not less than 20 hours a week in a clinical setting. What does that mean, supervised practice? Does that mean, as I said, that the collaborating physician sits or person sits with this person for an hour and discusses all 20 patients? What does it mean? As I said, I'm pretty intense. I see every patient with my student or my PA. And my PA, I have to say quite honestly, I know her well. I know her practice. She's had a very high quality neurology practice for about 20 years. So she certainly understands the interactions of all body systems and the interactions of medications. Again, she doesn't know all the medications, certainly not psychiatric medications, and all of the differential diagnoses, the criteria for psychiatric diagnoses. But she understands the concepts of physiology, interactions, drug interactions, dire things you have to look out for, what the things you have to consider across the board. So I have no problem with being a collaborating physician with her. I would have to know a whole lot more, as I said, about what the proposed curriculum really would be and who would be teaching it.
I guess I'm just thinking that the argument you're making that, first of all, unless you're a psychiatrist, you should never be prescribing any of these medications, which means that, every family physician, every pediatrician, every internal medicine, every other specialty shouldn't be prescribing these medications because they don't specialize in this one particular field of psychiatry. I mean, it feels like maybe we should be more worried about that.
No, I'm not saying that at
Um,
all. I'm not saying that at all. I don't have an issue with their prescribing because they understand the intertwined complexity of all of the body systems and all of the kinds of medications, not just psychopharmacology, that can be prescribed for people and the things you have to be aware of, things you have to look out for, and in differential diagnosis. If somebody, and so often, it's more often than not, that somebody in any specialty presents as, oh, this is a simple case of, and turns out not to be. Because human beings are complex, and as we get older, we get more complex because we tend to get more ill. No, I'm not in any way suggesting that other medical specialties should not prescribe psychopharmacology. The concern is with a specialty that is not a medical specialty, that does not have that background, that does not have that kind of training, that has not learned all of those intertwined things about physiology and pathology and medications, total body. That's my concern, not the folks who have had all of that medical training.
Any other questions for Dr. Lisa?
Just so, help me understand this. You feel that nobody, should be prescribing unless they have that, and I'm trying to understand what you mean by this, the medical background. Am I wrong in assuming that that's what you said, saying?
That is what I'm saying, because these are not trivial things. Medications are not trivial. It's not a cookbook. Any medication you take, heck, any over-the-counter thing that you take has interactions that people are often very unaware of. Interactions with other medications, interactions with other ailments somebody might have. Where are you going to learn that? Where are you going to learn those kinds of things other than through medical training? Where are you going to learn about the kinds of ailments that people commonly and uncommonly have? Where are you going to learn this other than through medical training? All these things interact. It is not, oh, look, you have this symptom, here's this pill, go and have a nice life. Everything interacts. I mean, the numbers of people who I see who very simply are taking a bunch of supplements and don't realize that they are overdosing themselves on the supplements and that some of the symptoms they're complaining about are actually due to that. Nothing is benign. And when you get into these medications, they are far from benign. Where are you going to get this understanding about intertwining physiology, all of our body systems, the way they interact, all of the medications, the way they interact in all the body systems? Where are you going to get this other than through medical training?
I think I understand where you're coming from. Now, I just have a question. If somebody, would you feel it was appropriate if a postdoctoral training program was accredited by the American Psychological Association? If somebody said, would you consider somebody going into that training, and after they finish that training, that they would be able to prescribe?
I don't know.
Because you keep asking who's going to do the training and what's going to be in the training.
That's right.
I'm thinking the American Psychological Association, if they accredit this training, wouldn't that be acceptable?
It depends upon what it is and who's doing it. I don't know what they consider acceptable. You know, who's doing the
Well,
training, who's doing the teaching?
Okay, how would we change this then? So that in your mind, an individual that went through some kind of training, and then went into 2 years of clinical work with a physician, that they would be, appropriate then to prescribe?
Yeah,
mean,
that's an
Because
interesting question.
Could I,
I'm just trying to
could you
figure-
suggest edits?
Yeah, well,
Um,
I'm saying it's an interesting question because that is something that, as I said, the 3 psychologists that I work with, who have no interest in prescribing themselves. They're perfectly happy with and very occupied with what they do. But we talked about that. What would feel like, you know, something which they would feel comfortable going out in the world and prescribing. Their feeling is, certainly at this point in the game, if they were going to take psychopharmacology courses, they would want them to be taught by people who are recognized experts in psychopharmacology. Right now, you are generally going to find those in medical schools. They would want to have at least a basic understanding of general physiology and the ways that emotional illnesses impact, let's say, at least relatively common illnesses, other things that people acquire, and vice versa, so that they would know what kinds of things to consider. And they would want those things taught by people who were experts in those fields. And still, generally speaking, you're going to be finding those in medical schools. You know, yeah,
Okay.
there are people certainly out in their own private practice who are also teaching and are therefore experts in some of these
Sure.
things. But their
Thank
feeling
you.
right now is that there are not, you know, certainly there are not that many prescribing psychologists in the country. And their feeling is that they would not right now, given what has been their understanding of what has been the training, they would not right now consider those folks likely to be expert enough that they would feel comfortable learning from them and then going out into practice.
Thank you.
Thank you so much, Dr. Lisa. If you would like to suggest some edits, then, and you could possibly email them to our committee assistant, we would really appreciate that. I think we need to, for the sake of time, because we only have 15 minutes left, I just wanted, if Dr. Barnett wanted to come up.
Could I just ask you to whom actually I would send edits?
Oh, actually, Stephanie Winters, you could send to Stephanie and Stephanie could
Okay.
certainly forward.
Okay,
Thank you.
thank you.
Welcome, Dr. Burnett.
Thank you. For the record, Rick Barnett, I'm a legislative chair for the Vermont Psychological Association. And you guys have heard an earful on this bill this morning. It's a lot of information and a lot of questions, good questions, a lot of perspectives, starting with Dr. Campo this morning and all the way through. So I would like to limit my comments here to both just address some things that have come up during people's testimony and then also try to answer any further questions that each of you may have. Again, I think the nature of this bill is definitely a collaborative one, as identified, even though it's been criticized as being vague. Collaborative practice, as Dr. Lisa has mentioned, you know, psychiatrists are trying to organize around collaborative practice models. Their model is a good one. What it entails typically is a psychiatrist might come into a primary care practice for an afternoon and sit down with a bunch of medical charts and review them and help with the medication prescribing. So that's one way to address the prescriber shortage and bring psychiatrist specialty into that. Obviously, prescribing psychologists is another way to do what this bill is about. As has been identified, there's a couple of things. One is how quickly and how many people are actually going to do this training. And we've seen, for example, in the places that have had prescribing psychologists for a long time, by the way, the concerns about safety, education, and training. No one has mentioned so far that if there has been so much concern about the current educational standards and training standards that exist in our bill here in Vermont compared to other bills, they're all relatively comparable. The sky has not fallen in these states where prescribing psychologists have been prescribing for years and are continuing to increase their numbers. But it is slow. It's a slow process. Part of the reason why it's a slow process is because we do have significant pushback from psychiatry, and they do make it somewhat difficult to get the training and the placements that are needed for clinical training. So one of the suggestions from OPR, which I think was a good one, it said something about a 14-month, 9 specialty clinical rotations. This bill has been through many iterations for 9 years. This is the 9th consecutive year a prescribing psychologist bill has been in this building. This is the first time. I'm grateful for all of you for bringing this up. This is the first time we've gotten this far, and we'd like to see it go through. If that means including the robust educational training suggestions that the Office of Professional Regulation has suggested, that's fine. It is cumbersome. It does make the barrier to entry that much higher. And also, if we have pushback from psychiatry or medical institutions because they have concerns about our training and safety, it might be difficult to get those placements, which is why I think in our bill as it's written, even though it seems like it's not very robust, 2 years, 20 hours a week in different clinical practices around the state, I think that's pretty significant. But it's not, as has been mentioned, it's not like a typical medical model. And that's not what we're trying to do with prescribing psychologists. As has been mentioned, we have 6 years of post-bachelor's training to become psychologists. It's a long time. And then to add 2 to 2.5 years of didactic training plus more supervised training before we can prescribe anything. It takes a long time. And our doctoral level training is significant. As Dr. Lisa mentioned, medication prescribing is not a trivial matter. It is not. But a lot of different disciplines can get and do have the training to prescribe safely. What we're offering is prescribing psychologists with their background in mental health for 6 years post-bachelor's. We have a lot of depth. And we remain in our primary role as psychologists, as talk therapists. And you add this piece where we can help more effectively with the medication prescribing and, as was mentioned, de-prescribing. I got into this field because I was working in a nursing home. I worked 5 years full-time at Rowan Court, at not Woodridge, but the other place down the road, St. Johnsbury. I worked in Morrisville at 2 nursing homes in St. Albans. Went up in Chittenden County. I would sit with patients in nursing homes who are elderly, and I would go through their charts, and I would sit with them and talk with them. And they were on a cocktail of psych meds and regular meds, a cocktail. So in my training as a prescribing psychologist, which I've gone through the training, I was like learning and looking at the charts and understanding what meds they're taking. High blood pressure medications, they're taking diabetes medications, they're taking 2 different benzos, they're taking 2 antipsychotics, 2 antidepressants. And we'd have the pharmacologist come in and look at these charts and be like, what's going on here? Prescribed by a primary care physician who rotates through. And so working together with the pharmacist who comes in and the physician that was coming in and me talking and pouring through these charts, we had a good model there. Why not simplify that by having prescribing psychologists? We can go into nursing homes and do our training in nursing homes. We can go into a primary care practice and do our training in a primary care practice. Do we need to do hospital rotations in pediatrics and surgery? And yeah, if that's what it takes to get this bill across the finish line, so be it. But it's not the only way to do it. And I do think that the uptake is slow. The Illinois model, where we got this 14-month clinical rotation thing, is one model. They passed their bill in 2014. We are in 2025, and they have something like 20 prescribing psychologists in that state. That's because in 2014, with all these cumbersome requirements, it was very difficult to get psychologists placed to do all this training that is required to be able to prescribe. Do we want to repeat that here? We can. It's cumbersome. Colorado just passed in 2023. Colorado has 8 prescribing psychologists. Their training and education standards do not include that 14-month rotation. But again, the Office of Professional Regulation did a very, very thorough review of this issue with their Sunrise review process. It took them 3 years to come out with the report they came out with in this January. That report has everything we need to show that this is safe and effective and good policy. Is there a slow uptake? Yes, there's going to be slow uptake, but it's good policy. It's safe. It's been vetted. I don't think it's necessarily up to the psychiatrist or a medical board to decide whether or not this is the way to go. It's a collaborative process here, and OPR has been phenomenal in doing their due diligence to figure out whether this is acceptable or not. So I don't think I addressed all the issues here, and I know we're running out of time. I do want to mention that Representative McFawn had said, if you look at the numbers, if we get 2 of these prescribing psychologists per county, even 1, it's significant. It's significant. And I also want to say one last thing. I don't know if you all got letters, but we got letters from 2 nurse practitioners, Deb Wachtel in Addison County, Katie Whitaker here in Montpelier, psychiatric nurse practitioners. We got letters from a family physician up in Colchester, Dr. Hobie Firstman, supporting this bill. We got psychiatrist Dustin Dippin in Lincoln, Vermont, Addison County, who supported this bill. We have Britta Reed, who's an OBGYN and also trained as a licensed clinical psychologist, so a medical doctor and a psychologist, wrote a letter of support. Pat Daly, who came out of retirement as a psychiatrist to help out in the Northeast Kingdom, wrote a letter in support of this bill. So there are psychiatrists and physicians who oppose this. There are psychiatrists, physicians, and nurse practitioners who definitely support this. So if we need collaborative practice models and we can work, we have people out there ready to support prescribing psychologists and help with the training. And those letters of support have come to this committee, or at least to the chair and vice chair.
Sunrise report that you just mentioned, could you educate the committee in terms of whether or not this bill we have in front of us was based on recommendations in that report?
100%. There was a very thorough review process of the bill that we had in 2021. Again, there's been a bill 9 consecutive years, starting with Representative Donahue in 2017. And the bill that we had in 2021 was the bill that we had in 2021. We looked at it, there was opposition, and we looked at all of the opposition, and so did OPR, and that was their, Lauren Hibbert and Jen Colin came in and they said, look, we vetted this bill is very different than the bill we did during our Sunrise review process because of the Sunrise review process. So it's been modified to the acceptable changes. The standards were not there in the previous bill.
All right. I'll ask you the same question I asked Dr. Campo about access to pharmacy. Do you feel that is a valuable relationship to have for any provider prescribing medications? And is that something that you would utilize in your own practice?
I can't say enough about our pharmacist friends. PharmDs are phenomenal in their ability to look at medicines and contraindications, drug-drug interactions, drug-disease interactions. And I mentioned earlier in my comments that working with the pharmacists who came into the nursing homes was awesome. They're an incredible resource. And I also know that PharmDs have also sought this same type of scope of practice expansion for say, pharmacists who have a doctoral degree in pharmacy to be able to prescribe and de-prescribe psychiatric medications. So they are phenomenal partners in this. I don't know if anybody from the Board of Pharmacy has weighed in on this particular issue. And I know there was language, at least in the previous bill, around collaborating with the pharmacists, but they're great partners in this, 100%. Now I have one across the street from where I work, and we have a good relationship. So yeah, it's very important. again, this is all about collaboration. It's about working together.
Thank you.
Any other questions? Well, thank you very much.
Thank you.
Great, we're done for the morning. Just in the nick of time. So we are back here. After the House floor. We have 3 p.m. because that's
Scheduled for
okay. So we're back here at 3 p.m. or 10 minutes after the floor. All right.